Okay, let's go ahead and get started. So good afternoon, everyone. Happy Friday. I hope everyone's doing well today. Thank you so much for taking time out to join our ECHO session today. Before we get started, can I please have everyone take a minute to set their Zoom name as their first and last name, as this helps me with identifying who is on. Thank you. Next slide, please.
Oh, hang on. It's not. There we go. Sorry.
If this is not your first ECHO session with us, then this will look familiar. This is the structure of all of our ECHO sessions, starting with announcements, introductions, followed by a didactic session. So today's topic will be focusing on MCI, what it is and how to prevent progression. And then we'll follow with our collaborative case discussion, followed by closing and reminders. Next slide, please. So to make sure the sessions run smoothly, please remember to mute yourself when you're not speaking to prevent background noise. Please introduce yourself with your name and location prior to speaking. Please maintain confidentiality when speaking about your clients by refraining from including any identifying information. And please respect others in their opinions. Next slide, please. So we are CME accredited. Our main objective is to power in providers to feel capable and comfortable with the assessment and care planning for dementia and to expand access to geriatric specialty care throughout California and beyond. So today's session is accredited for 1 CME credit. Certificates will be sent out by our CME office at the end of each month and will outline the total number of hours you attended. And many other licensing boards like the California Board of Nursing also recognizes CME for reciprocity. Next slide, please. So our series is a part of the HCBS Dementia Care Aware Award, which is supported by the California Department of Healthcare Services. One of the main goals for our grant is to create a dementia-friendly California for the population in need of equitable and excellent care, which is the older adults, and to train geriatric specialists, primary care providers, and health profession trainees, and to help expand our geriatrics workforce. Next slide, please. So we would like to have everyone take the time to quickly introduce themselves on video, but since we have quite a few individuals on the line, which is great, we'll go ahead and have everyone introduce yourselves via the chat function if you can. So when doing so, please list your name, role, site, and location. Next slide, please.
Oops. How do I go back?
In the meantime, we'll go ahead and have our hub team introduce themselves on video so you can get to know us. I'll get us started. My name is Nahal Khan, and I'm the project manager for Dementia Care Aware project at UC Irvine Health, and we are located in Orange, California. So I'm going to hand it off to Dr. Sehgal.
Hi, everybody. Welcome. I'm Sonia Sehgal. I'm a clinical professor in the Department of Medicine here at UCI and work in the Division of Geriatric Medicine and Gerontology. My practice site is in Orange and Laguna Hills with UCI Health. It's really my pleasure to welcome you today.
Thank you, Dr. Sehgal. And Dr. Lee.
Hello, everyone. My name is Jung Ari, Associate Professor in School of Nursing and working with wonderful UCI Health geriatric teams. And currently, I'm doing the caregiver home visit intervention study. Nice to meet you.
Thank you, Dr. Lee. Next slide, please. So today's speaker is Dr. Tam. So Dr. Tam, I'm going to hand it over to you if you want to take a moment to introduce yourself.
Great. Thank you, Melhill. So my name is Steve Tam. I'm one of the geriatricians here at UC Irvine, part of the Senior Health Center team is where we see patients. I am been with UCI for about 14 years. My background is seeing primary care patients, but we do a lot of the memory consults for our patients. As in my background, I did like an extra 2 years. Extra year in terms of geriatric neurology and dementia work, where we also did a lot of clinical trials and research too. So that's why I'm particularly interested in it. Okay. So now I can go ahead and get started. Okay. So thank you all for being here today. Today's session will focus in around mild cognitive impairment. We'll talk a bit more about what it is. And how to treat as well as prevent it, or what options there are to treat and prevent it, especially when we are discussing the diagnosis, the syndrome with our patients. Okay. So objectives, we'll go over, I have 2 cases we can talk a little bit about. We'll go over some of the definitions and what defines what MCI or mild cognitive impairment is. We'll look at, I believe as part of the dementia memory workup evaluation, that's part of another talk. So I'll actually not put that in, but it pretty much falls along that same line. But we'll talk more about the treatment and preventing of progression, or at least review what's available out there. And then we'll go back over to our cases afterwards. So here is first case that I have. This was actually a patient that I had in the past year. I brought her in, brought her into the talk, to the discussion, because I actually saw her back in follow-up this past week after it's been roughly 9 months or so. And so this is a woman who initially presented with short-term memory complaints, forgetting details, words, names, staying on task for at least the past year or so prior to coming in. And she had actually reported having some hallucinations, or the family had reported her having hallucinations in the form of her seeing her dead, passed away parents, which actually had resolved about 4 months prior to her coming in. So when you delve into her history a little bit more, you find out that she actually has a history of chronic back pains, has been on opioids intermittently, most recently taking some Tylenol with codeine, not on a regular basis, but on an intermittent basis, because now they put a pain stimulator in her. She's had an epidural. She's mostly wheelchair bound at this time, and can take a few steps, but due to her back pain, spinal stenosis, prior spinal surgery, those things included as a source of it, she's pretty limited in terms of her mobility and her exercise ability as a result. There was also a history reported of chronic migraines, and on her medication list, she reported being on nortriptyline, Klonopin, Depakote or valproic acid, all for the migraines in terms of the reasons for them. And they'd been on for the past couple of years or so in terms of their presence, and then also getting Botox injections for the neck pains and the headaches that contributed to it. There was also a history of diabetes, hypertension, hyperlipidemia, a history of difficulty sleeping without a real workup previous to that. And she actually, interestingly enough, there was an outside physician who had given her Aricept or donepezil 6 months ago without like a full-on diagnosis of what this was. And so, they attribute that the donepezil helped with the hallucinations, but I think most folks on here can tell based on that history, there are probably a lot of things that could potentially contribute to not only the memory or the cognitive concerns you would think, but also some of the neuropsychiatric symptoms in the form of those hallucinations. And so she had a MMSE that was done at around this time that we did for her, and it was about 26 out of 30. And most of that was actually the points missed was actually involving orientation and on attention in the form of the serial sevens rather than primarily the memory portion of it. She actually missed just one on the recall. She actually had also been referred for additional neuropsych testing in addition around this time. And it pretty much confirmed kind of like what, like that level of an MMSE essentially. This was the impressions on that neuropsych testing that was done. But it basically, so it read off as a mildly abnormal protocol. The primary deficits were actually in letter and semantic fluency. So those are your abilities to come up with words and your knowledge based off of, some stimulating factor like a letter, first letter, let's say, and may reflect the earliest signs of an acquired change. The memory itself on this testing was actually in the normal range, which isn't surprising. Again, on the MMSE, she was missing 1 out of 3, but based on their history, you would think it would be more. So, the where this falls, it was actually the lower end of average based on that age and some of the other educational background type factors that go into the way they look and on that curve for rating performances. But there was a tendency for intrusion errors. That's when you start to put in things that you think are actually the right answer, but they're not. So they were suspicious for some signs of decline. The neuropsychologists did look at the same kind of history that we obtained, and that those might be factors that could be contributing etiologies to the cognitive dysfunction that she had. I think most importantly, she noted about the chronic pain, the medications, the impact on the mood, the sleep issues that were reported, same kind of things that we actually go about to with it, as well as this hallucinations, which we weren't quite sure what the significance of, right? So on the neuropsych testing, the impression was that she didn't meet criteria for dementia based on the testing results and how she performed itself. But that's also, again, on a separate talk, they talk about how we make a diagnosis of dementia. But from this and that kind of history, she wasn't meeting the criteria for dementia, and the most appropriate clinical diagnosis at this time was mild cognitive impairment, and it was actually listed as non-amnestic type there, because again, memory was actually not the worst part of this testing. So with that being said, what is mild cognitive impairment, or MCI? So initially, when MCI, or mild cognitive impairment, was first introduced or used, it was primarily looking at trying to identify folks that might be kind of like a precursor for Alzheimer's disease or dementia. And again, it was developed in many ways so that we can try to identify folks that might be candidates, that, hey, they're going to be at risk for developing a dementia down the road. These are individuals that we should identify earlier on. If we have the treatment, try to get them treatment, try to prevent them from ultimately progressing and developing into the dementia conditions at that later on down the road. So that was the primary purpose of even having this, and so that we can identify folks early. And at that time, a set of different criteria was basically laid out that pretty much has stayed more or less the same. There's been slight evolutions of this in terms of what it encompasses, but for the most part, the broad components that make up what MCI, or mild cognitive impairment, has stayed relatively the same. And there's different forms of mild cognitive impairment, or MCI, out there. We just talked about the case. In that particular individual, the impression for the neuropsychological testing was that it was actually a non-amnestic MCI, meaning it was non-memory dominant in terms of the cognitive impairment there. So the primary one that we do think of is the individuals that have an amnestic MCI. In this form of MCI, by definition, is the individual has a subjective memory complaint, whether it's from the individual or for some corroborating collateral informant, that when we actually put the individual to task and objectively test them, we can identify an actual objective memory impairment in a memory test, essentially, that their other cognitive functions are generally preserved, that they can still maintain themselves, they can still do their activities of daily living in terms of their general function, and that they don't meet general criteria for dementia, which is pretty much all of these, in addition to not being caused by some other concurrent medical or psychiatric etiology there too. So those are the primary components that would make up a mild cognitive impairment. And the amnestic part is where it's an objective memory deficit that's there. Okay. Where this falls in terms of the spectrum of memory changes as we get older, is that, the way I kind of take it and explain it to patients to help them understand, because a lot of our patients will come in and they're concerned about their memory. The biggest question is this, just because I'm getting older, or is this actually Alzheimer's or dementia? That's a common question as well. But the way I explain kind of like what MCI is, or what dementia, major neurocognitive disorder, and age-related changes are, is that essentially on that memory spectrum is that there's pretty much 3 large buckets of memory issues folks that might experience as they get older. Again, this is outside of other conditions that might cause a cognitive change, like, you know, they're on a certain medication or they just had surgery and anesthesia. They're in the hospital because of delirium or whatever the case might be on there. So, but those 3 large buckets are really, there is a true age-related memory decline, that this is a normal decline in cognitive function. It's more, it's likened to like an efficiency issue, how well you come up with a word or a name. Seeing somebody on TV, an actor, and like not having the name right away, it may take a little while longer, but essentially it could still come to you. And that those kind of changes don't actually impact daily function. So that's one major bucket of memory change with folks as they get older. The third bucket is flipped. Oops, did everything go black or dark? Oh,
No, we can see. We can see.
let me blank something out. I think my Epic system just kind of took over. I'll be right back. Okay, here. So age-related decline is a real bucket of memory change as folks get older. Another major bucket or group is the dementia category. And this is when there is memory changes, cognitive changes, and they do significantly impact daily living from prior levels of functioning there, okay? Patients always ask, what's the difference between Alzheimer's disease and dementia? The easiest way to explain it, I find, is that dementia is the big category diagnosis or term, and Alzheimer's disease causing a dementia that's probably the most common cause of a dementia on there. That's probably the easiest way to explain that question. And then we do identify this this third or in between bucket or category of memory change for folks that get older, in the form of mild cognitive impairment or MCI. This is what happens when there is a decline in cognitive function, an objective decline, but the daily function, the activities of daily living are not impacted by it, okay? So that's kind of 3 broad definitions of what it means in terms of MCI, normal aging related changes in dementia. Here we go. So 2 slides ago, we brought up the topic of amnestic MCI, which is probably the more common one that we see or folks that are concerned about out there. But there are other forms of MCI or mild cognitive impairment as well. And that can come in non-amnestic versions. And you can have one domain involved or multiple domains involved. And these would involve the other cognitive areas. So attention, problem solving, visual spatial acuity, language. And then there's the additional social graces one, which DSM-5 added on in terms of helping identify folks that might be at risk for developing frontal temporal disease on there, okay? So those are the other kind of domains. And, you know, the testing that we do, whether it's the screening measures, like the GP-COG that's introduced in the DCA curriculum, or the MOCA or the MMSE, they do break it down into these different cognitive domains. You may not realize it, but when you actually are asking these questions, you're actually testing certain parts of the brain by doing so. And so on the GP-COG, you check for orientation by having them draw a clock. There's some visual spatial planning that's involved in that. By having them set their hands to a certain period of time, you're actually checking their executive function and their problem solving abilities and their planning abilities when you do that. Getting the information and the recall part, of course, is the memory, but sometimes that language is also involved. If you look more carefully at the MOCA and the MMSE, same thing. You actually see that they're broken down into the different components of cognitive function that are actually being assessed. Because a lot of times we go through, we're just asking these questions and we may not put it into context that we're actually asking about their visual spatial abilities, their executive, their problem solving, and their planning abilities when they do so. Memory, of course, is pretty evident. But when you do things like serial sevens or spelling world backwards, you're actually checking their ability to pay attention and keep focus and concentration by doing so. Language skills are assessed on these tests, again, realizing it there or not, in addition to the memory portions of it, okay? So it's something to keep in mind. The other thing about MCI, there's different terminology that's out there. MCI is probably the more common term that you'll hear or see, mild cognitive impairment, but sometimes it's used kind of interchangeably with this term mild neurocognitive disorder, which is a DSM-5 construct that was brought in to help mirror major neurocognitive disorder, which was the terminology trying to replace the word dementia and replace some of the stigmata that's associated with it. But it's more or less similar in definition, and for clinical purposes, they're used very interchangeably on there. You might hear the terms like preclinical AD or Alzheimer's disease out there. That's actually different from mild cognitive impairment. And again, these are probably more research terms to help folks identify for different studies and clinical trials and whatnot. But the term preclinical AD or Alzheimer's disease actually refers more to folks that have an MCI-like appearance, but they have findings of plaques on whether it's amyloid studies or lumbar punctures and CSF studies that help identify them as such, so that they're labeled as preclinical, because those are some folks that we try to identify for some of the research trials that you hear about, especially in the news these days, with the different Alzheimer's drugs and medications that are out there. Age-associated cognitive decline, and there are others out there too, is another term that I think can get confused with MCI or mild cognitive impairment, but this more or less refers back to normal aging related change of memory or cognition at this point. So what are kind of normal and not normal changes in terms of memory performance or cognitive function and performance? So I mean, if you think about these kind of make sense, right? Like sometimes we all can forget a name or have trouble finding the right word. A lot of times they'll come to us later, like we're showering or we're eating or we're doing something else and we're not focused on it. We get enough rest and then we get that name or the word again in a delayed fashion. So that speaks to what goes on in our brains as we get older, or if there's other distractions or other stressors are in our lives. Because what it is that our brain cells, the neurons, the dendrites, the connections, they're having an efficiency issue in their ability to pull up this information essentially, right? And so it takes longer. It's easier to forget a name, find the word, especially if it's not something that it's somebody that we're speaking to regularly, or a word that we're pulling up in conversation on a regular basis, right? When it's really abnormal, though, it's like it happens when we have a family member that should be pretty familiar with us, that we see on a frequent enough basis that you no longer are recognizing them, right? So that's pretty significant change. When we start putting in words that are completely out of context, because a lot of times we'll have trouble finding a right word, and we might substitute something in that means pretty similar. But when you put in a word that doesn't fit it at all, hot instead of cold, something along those lines, those would be instances where something is much more abnormal in that kind of case. Okay. Orientation, usually we may like lose a date. We might even lose the year when the year turns over. We frequently do that when we sign and date our orders, because it goes from 2022 to 2023 right at the end of the new year. We'll make that mistake pretty frequently in terms of still putting in 2022 because you're not getting used to it, right? Or in terms of orientation, you're going to a new place or to a place that you might visit only once a year, not having the directions for it down and getting there easily. Again, those are more likely to be normal related changes than if you're getting lost in your own neighborhood, if you're getting lost in the supermarket down the street, trying to get there when you've gone there regularly in the past. Okay. we can have trouble balancing our checkbook, as we get older, or we have more stressors or other things on our plate. And to be honest with you, how many of us actually still balance our checkbooks these days, right? I mean, with all the technology that's out there, it probably is a little bit of a lost art, because our banks have kind of like a running tally of what our bank accounts are doing, right? So the less you do it, the more trouble that you essentially have balancing your checkbook efficiently. Okay. What's abnormal about that is when we can't recognize numbers altogether. So again, instances where we try to identify something that's truly wrong here, right? Misplacing items, keys, glasses. I mean, again, we all do this, especially when we get distracted. May get a little bit more frequent as we get older, and other things are going on. But we generally don't put things in the wrong place pretty outrageously. And the reason why I put putting iron in the freezer is because I have had a patient had that happen to them, where they went to the freezer and they found an iron in there, so those things are kind of like more or less red flags or information that's important in terms of helping you gather the necessary information when there's like representing a true kind of decline in individuals. Those activities of daily living that I keep referring to, are pretty much the ADLs, the things that you need to do to go about taking care of yourself during the course of the day. So everything from bathing, dressing, driving a car, taking your medications, taking care of your finances, all parts of ADLs. When we look at functional status in terms of memory evaluations and cognitive evaluation, it also not only may represent ADLs, but we might take into account also if they're actively employed and working, whether or not there's like true decreases in their prior performance levels in their work and their ability to do their job. So MCI is important because it is frequent enough. We know that with dementia or major neurocognitive disorder, the prevalence tends to increase with age, and that it more or less doubles every 5 years with age, in terms of, again, dementia, major neurocognitive disorder, so much that it's probably makes up, when you're 85 and older, you're probably looking at about 33 to 50% prevalence, depending on what studies you're reviewing. For MCI, it's not necessarily a doubling rate that's there in terms of the prevalence, but it is quite frequent enough in terms of every 5-year category grouping. So you see it enough there. And I think the other important part of MCI, again, the original reason for this construct to have been made was so that we identify folks that are at risk of developing dementia. And the different studies have indicated that it could be a 10 to 15% risk per year compared to normal controls of about 1 to 2% a year developing a dementia. So we know that individuals with MCI have a higher risk, and especially if they're due to Alzheimer's disease is the underlying driving factor in this. Okay. Now the thing about it with MCI is that essentially you can do one of three things, right? You can stay stable, you can improve, or you can get worse, which is that progression into that dementia territory. Okay, so we do see individuals that might stay stable in this state. They might get a little bit better. A lot of this is that, all these different studies that have been out there, there's a lot of heterogeneity in terms of the makeup of this, difficulties with diagnosis. A lot of it is clinical judgment based. More and more these days, we're trying to identify whether those amyloid PET scans and the CSF studies, whether or not they're a future like blood tests, whether or not they're going to also be helpful for this here. Okay. But in the past, there is some heterogeneity to it. There are things that look like MCI due to medical conditions. So that's why there is some increase or stability to this as well. And a lot of co-mixing of these different conditions here. Okay. So why is it important to diagnose MCI? Why even diagnose a memory problem? So again, the previous slide, we just talked about how having a diagnosis of MCI, there's a potentially higher risk of developing a dementia down the road, right? That prevalence or the risk for conversion increases to go into that territory. But it also is important because it helps patients and family really understand, why they're feeling the way they are, right? Any memory and cognitive problems, what it could be due to. Okay. That evaluation, again, I won't go too much into the treatment and evaluation for workup of memory, but it's essentially the same as any kind of memory workup. But part of that workup is to try to identify any reversible causes of memory or cognitive impairment that's not a Alzheimer's disease or a neurodegenerative reason for it on there, right? We don't know exactly what percent of cases of reversible causes are out there. The different studies, I mean, it's hard, obviously, you can imagine, but it could be anywhere from 2 to 15% of workups. Just, it depends on what study you look at on there. So there is value in trying to identify anything that might be potentially reversible. That being said, not everything is reversible in that case. Okay. Making the diagnosis MCI is important to help, again, not only help them understand their memory cognitive problems, but to be able to kind of tell patients and work with patients and families on how to plan for the future, what to be able to look out for potentially as well. Some other causes to look for that look like MCI that are relevant and that might have a potential reversible component to it are any psychiatric illnesses or disorders, so like depression, medical illnesses like hypothyroidism, and I've seen cases where patients have come in with pretty profound hyperthyroidism. You correct that, and their cognitive function improves significantly, and they're back to a normal state of function. Head injuries, the amount of time it takes to recover from a head injury. Stroke is one of those scenarios where you might have some cognitive impairment after a stroke, but that might stabilize or even get better right afterwards. Okay. And then your underlying degenerative processes that probably make up that 10 to 50% of progression more often than not, whether it's Alzheimer's disease or Lewy body or some other etiology. So part of the prevention of MCI and treatment of MCI, this is, I think, an important question. More or less, we don't have any proven treatment for MCI. Likewise with dementia. I mean, I think those are all the things that are being worked out right now. But the approach to this, I think, when a person or individual does have this diagnosis of this syndrome, is what can you do to try to help prevent it from getting worse, more or less. So we, again, looking for any potential reversible causes. Those are the medical conditions, any deficiencies in any kind of state, looking at treating any mood and psychiatric conditions, sleep issues, looking at medications and any potential side effects from those medications. Those are important. The sleep issues, I think, is an important thing. Identifying sleep apnea related. We know more and more that sleep issues, untreated sleep apnea has associations with memory loss and cognitive impairment down the road. We just don't have yet enough information on what treatment for those sleep conditions actually does in terms of whether or not it staves off dementia, prevents MCI from getting any worse yet. But those are some of the different ongoing studies and trials out there where folks are trying to analyze that right now. We talk about vascular risk factor modification. There hasn't been any great, complete, dedicated RCTs, randomized controlled trials for this, where you're singularly looking at keeping an individual's blood pressure at a certain level, and the primary end goal is a memory related issues. A lot of them are off of secondary outcomes and analyses, and so more of the information more or less is based off of those and epidemiological studies, where we see that keeping blood pressures in reasonable levels, not too high, not too low, probably is more beneficial than not. That's the same with diabetes management, statin treatment. Some of those have been kind of controversial in that there's some studies that have evidence for it, and some studies that argue that there's not much of a significant change as a result. So, but more or less, I mean, you still want to keep diabetes under fair enough control, cholesterol under reasonable enough control, depending on what their conditions are. Smoking cessation is, all recommended for other conditions, obviously. Exercise has been something that's been looked at pretty, for a while. I won't say extensive enough, but it probably does show some modest benefit. Probably one of the larger meta-analyses have shown that upwards of like 1,500 patients almost, that an MMSE was improved by 1 point. You can argue what's the benefit of that 1 point in terms of trying to prevent progression of disease. But there might be something there. But if nothing else, exercise does provide other health benefits, especially when you add in like social components and whatnot. There are some exercise studies that UCI, other institutions have done, where some of the data is still kind of waiting to be finalized and out there. So hopefully we'll get more information. So, but a prescription for exercise isn't, I think, unreasonable, just due to the other health benefits alone, especially if you combo that up with like social stimulation and other things with it too. So, that's an important thing to consider if they can do it. Cognitive training exercises, we talk about like brain games, studying and do whatnot. Again, it's another one where we're starting to look at this, trying to figure out what's the value of this. There's only been more smaller studies in terms of size that show that there probably is some shorter term waning effects. The issue is always going to be whether or not you can continue to keep up something, right? We as a whole like only knew so much algebra or geometry while we were doing algebra and geometry, right? For those of us that are here, like how much algebra and geometry do you still know? I mean, you're not practicing it regularly. So I can't help my teenage daughter these days with her geometry homework because I just don't remember it the way I used to when I was actually studying it. So that's the same kind of concept. When you're kind of doing things regularly, it helps reinforce that information. And that's probably true with some of this cognitive training and exercise too. What are you doing on a regular basis? So bottom line is that there's a need for further and larger studies related to this, but it doesn't hurt. And I think it kind of helps them stimulate. I think the interesting thing is that a lot of times we're relying on lists and we're relying on our iPhones and we're relying on different reminders that, that we're selling ourselves short in a way to actually try to test our memories here. Okay. Medications, supplements, really, I mean, despite what ads are out there with discussions about Prevagen and whatnot, or ads for Prevagen, there really isn't any kind of proven symptomatic or preventative benefit in terms of those, as well as herbs and supplements. None of the studies like ginkgo biloba, phospholipid supplementation, the short chain fatty acids really have shown any benefit to them. NSAIDs have been one that's looked at and really no evidence of benefit. Cholinesterase inhibitors, your Aricept, along with your memantine, they really haven't been supported in clinical trials for use of preventing MCI from turning into Alzheimer's disease. That being said, there are plenty of patients that we might try them on an Aricept for, maybe a defined period of time to see if there is any benefit, if their difficulties are particularly troublesome. The drawback is really just whether or not they can tolerate any side effects related to it. Okay, but it's reasonable to try it if you want to, just knowing that it doesn't actually change the outcome of it, because they might show some improvement in terms of the ability to do certain things. Going back to our case presentation, the individual thought that it was helping them with their hallucinations in that sense, but it doesn't look like that will be the solution for this. There are other studies looking at things like intranasal insulin growth hormone that might show some benefit. It's just more studies, more information, data will have to come out related to it. So the big ones in the news right now are aducanumab and lecanemab. And they're essentially two anti-amyloid antibodies that are out there that they've gotten like FDA approval, accelerated approval process with a lot of information still to come, I think, related to this. A lot of decisions regarding CMS approval for them, especially with or related to lecanemab. But these are medications that we know are anti-amyloid. We know that they can clear out amyloid plaques, but the clinical benefit has been kind of questionable for some of these. Lecanemab, when that data is published, looks like it will probably be a little bit more effective, but I'm not sure what it looks like. For aducanumab, the original paper or the original study with this showed that there was some reduction in the clinical dementia rating scale, something called the sum of boxes. But you know what that really translates to, nobody's really sure yet. And probably in part is just that, you know, if you think about the brain, right, and you have amyloid in the brain, just because you remove the amyloid, you know, the damage that's done by the amyloid is still potentially there, right? I mean, you're disconnecting neurons and dendrites and cells from talking to one another. So after that damage is there done by the amyloid, well, you know, you can remove it, but what's actually going to repair those neurons in terms of talking to each other, right? So that's probably why, you know, or that's at least one of the hypotheses in terms of why you can make a dent in the amyloid, but not see so much a clinical significance in terms of performance on different measures without some other component of therapy involved to help, you know, those neurons talk to one another again. And so I think this is a part of the solution, hopefully, but we'll have to, you know, combo it up with some other things in order for it to be like fully effective, I think, in the long run in the future. So again, hopeful, but we'll have to see. I think the biggest parts of these two therapies, again, for trying to give to folks that have MCI due to Alzheimer's disease or mild Alzheimer's disease, is really the adverse effects related to them, which are the concerns about ARIAs, which are amyloid-related imaging abnormalities. And we've seen them in clinical studies happen in about 40% of patients with aducanumab, and they involve microhemorrhages and edema. Okay, and so those are big enough concerns. Costs, infusion time, MRI monitoring for safety, all those things are other issues related to these medications here. So those are kind of like the measures that I have. I mean, I know that wasn't very positive, but in many ways for our patients that have MCI, that's what's available. And so really looking for reversible causes, trying to optimize their health in many aspects, right? Reviewing their medical conditions, getting their different conditions like their blood pressure, their diabetes, those things under control enough, making sure that they're active, right? Physically, socially, mentally. Those are probably the biggest benefits that are out there right now until there's more known and more treatments actually available, right? So going back to this individual again in our initial case presentation, I actually saw her back this past week, and she actually had a MoCA of 29 out of 30. She reported doing fairly stable. Her hallucinations had not come back. And really, you know, there wasn't much that we did too much other than what we kind of talked about in terms of trying to prevent. We talked about trying to get rid of her opioids, the codeine, as much as possible, not taking that as much as possible, but having a balance, knowing that she truly is back pain, trying to get her more active. So she did some physical therapy afterwards. She's able to, you know, walk maybe 100 feet now with a walker and assistance. She actually worked really hard for that. Having her try to minimize some of her medications like the Klonopin, and then getting her, you know, reassessing her sleep. She actually has no more sleep problems at this time as of this past week here. A lot of that was probably more due to the pain, due to some of these other, like her medications and some of other things going on and stressors and whatnot. So her MoCA stayed fairly stable. And again, if you go back to the original neuropsych report, these were the things that were kind of highlighted, right? That there was deficits in letter and semantic fluency, trouble with some of her language abilities. Again, that non-amnestic component. Her memory performance generally fell in the normal range, lower end of average. She had chronic pain, which we tried to talk about and address. Her mood was better. Her sleep was better now. We talked about her medications to her. I'm not really convinced that the donepezil really resolved her hallucinations, even though she was. But I don't have a problem with her continuing to be on that. I think if she felt like it helped to a certain extent. And once again, they said it was the non-amnestic type. So interesting thing was that when we did a MOCA, she was actually 29 out of 30, which is kind of a flip from the MMSE. We usually see people do worse on the MOCA than an MMSE. So it kind of tells you that, hey, this isn't so much, a significant neurodegenerative etiology like Alzheimer's likely in this kind of scenario. And, where she missed the point on the MOCA was the fluency compartment of it, right? So that question about fluency and naming as many words as you can with the letter F, she couldn't get to the 11. She was at like 7 or 8. And so that fits with the original, the second sentence right here in terms of the statement, deficits in letter and fluency. So there actually may be a little bit of a fixed deficit that's there, but it's still in line and more or less, on a MOCA hasn't really much changed in this kind of circumstance, right? And I can tell you that the things that we'll do with her and we'll continue to do with her is to continue to monitor her neuropsych testing, how she performs with that, monitor for any functional decline, continue to treat her, medical and psychiatric conditions as much as possible. Just really quick to think about, this is a second case that I saw this week that was, I thought, relative or interesting. It was another 76-year-old who has a history of RA, high blood pressure with fluctuating blood pressures, sleep apnea, who's not using her CPAP consistently. She came in with memory complaints and actually been followed by a research study for about the past 6 years. Only in about the past month is where she actually showed a drop in her some of her categories, and they were in the form of memory and language areas. So she fit a MCI multi-domain, amnestic multi-domain type diagnosis is what they gave her. But it was part of a research study, so they didn't really go over the full implications of what this was. She came in to discuss these results. So I basically spent about 25 minutes with her at this time just to go over what those results were, what they meant, what MCI was. They actually said what she interpreted in her meeting with them was go to your primary care doctor for medications for MCI. And it was, she was kind of heartbroken when I told her, like, there isn't any primary medications for this per se, we'll kind of do this and that. And, we can consider a trial of donepezil down the road. I wanted to get an MRI on her to make sure she didn't have any stroke things, given her history with the blood pressure and everything else. But, and she was very agreeable to that. She was very appreciative of understanding what this was, what other things that might more importantly affect her cognition and memory, like the sleep apnea, like her pain, like the blood pressures being out of control in that case. So we'll have to see what happens with her. Okay. I think that's it. So I'm sorry if that was a little bit fast. Manahil, is it just open up for questions then?
You're right on time. Yes. So thank you, Dr. Tam, for your great presentation. So at this time, we would like to open it up for any questions. So please feel free to unmute yourself or put any questions in the chat.
We do have a question from the chat. The question is, what is your opinion in using slums? I do work in telepsychiatry, telemedicine, and I see that slums for me is more virtual friendly, and I'm so limited with MOCA testing.
Yeah, I mean, I think between MOCA, MMSC, GP Cog, they all serve their valuable purposes, right? You'll find that when you're actually trying to make a diagnosis, or if you're trying to screening, again, what are you trying to accomplish with it? What access, what resources that you have available to you? I think again, your slums has the same thing where you can identify certain components. I actually like the slums a little bit more than MMSC as well. I think it is a little bit more friendly than the MOCA as as you're on too. So I agree with you. There's different breakdowns and easier. We're getting these kind of programmed into our EMRs so that it's easier to access to, so that we're not always scrambling around looking for sheets. But I think slums is just as good for in terms of a workup. There's not really direct head-to-head testing between the different options. If you do identify something, you you could go on to further testing, neuropsych testing. But again, I think a lot about diagnosing dementia, MCI, ends up still being about how comfortable you are in terms of your clinical judgment. And I think that's what we want folks to really get to, and just have that comfort level with it, regarding that. So.
Thank you, Dr. Tam. We have another question. Do you know about light therapy using gamma ray 40 hertz in relation to dementia?
I don't know in particular. I mean, I think it's probably on the lines of, there's different therapies, different small studies of these different modalities that are out there. Like, just like ECT, there's magnetic therapy related to that too. I'm sure light therapy is probably along those same targets in terms of having like some smaller studies out there related to it. I would say that light is important for our patients in terms of having the right levels of the light exposure, having high enough exposure. I did some work in a neuropsychiatric ward before for folks that had that were pretty large portions of dementia. We had really, really bright therapy in terms of light there. I'm not sure exactly what gamma ray, what frequency of the light was being used, but I just, I know that our geriatric psychiatrists in that kind of department, they're very particular about having as much bright light exposure as possible during daytime to try to keep in line with sleep wake cycles. I think that there's probably more to come from all this. We probably just don't have enough study data to support it. One thing that's kind of an interest that we always pick up on every time there's like a time change, right? Daylight savings. You or I probably all feel a little bit out of it, slow or sluggish after that happens. Just imagine if you're an older person that has some Alzheimer's disease, memory impairment, you're going to be even a little bit more disoriented in particular. And if you or I kind of have that difficulty figuring out what the times are and whatnot, if you have a memory problem, imagine what that means to related to it. I think that's all I can really give you related to that.
Thank you, Dr. Tam. One other question. Can you talk about malingering and memory loss?
Malingering from what standpoint on there? Can you define that?
Oh, Sandra, can you, would you like to unmute yourself and clarify your question?
Sure. Yes. Patients who are pretending to have memory loss, do you encounter that? And can you tell me like what would be a red flag? I'm thinking of a patient that I recently saw that seemed to have a great memory for some things, and then she seemed to have like this very strange memory loss for other things that were in the same time period. It was just, I thought maybe it was more psychiatric or malingering.
Yeah, I don't know. I think most of our patients would actually say that they don't have any memory problems rather than the vice versa. So I don't know that I've really encountered that scenario. I mean, obviously I don't know that there's a lot of data about that kind of situation. When we think about malingering and psychiatric illnesses, they're usually in the form of some other kind of like presentation from, like all the situations I've ever come across, eating other health conditions like their blood pressure, their medications and whatnot. I don't know that I've really encountered anybody from that sense. I think, you can, in the hands of that might be one scenario where it's hard to screen for per se, that you would try to find more resources and like a good neuropsychologist. Neuropsychologists are pretty good. Like they really try to get you in the right environment. They're pretty keen on, whether somebody is giving a good effort in terms of what they're doing too, because they're pretty observant about that. So that's one thing that the psychologists, the neuropsychologists, the operators that we've worked with have always kind of like, made statements about patient was in a good mood, was actively trying to participate in this test. They are pretty keen or trained and looking for that. That's a pretty tough situation. I think you kind of need to get a lot more folks involved,
Right. Well, one thing I noticed was that she forgot she told us she had glaucoma. It was kind of a scary situation.
Yeah.
But she remembered a lot of other things. So it was hard for me to tell, you know,
Yeah.
what would differentiate why she would forget some things and not others.
I mean, one thing that we would say too, like if you look at our MMSE or MOCA or slums, a lot of it is actually like language based, word based, right? There's some visual components to it. Again, this is where like a regular screen might be harder. And you know, some neuropsychologists out there do a lot of other tactics to go test like visual memory or other things as well. So it sounds like it would be a situation. And they also say statements, has their glasses, has a hearing aid on, has a hearing assist device, or
Yeah.
hard of hearing, you know, like those would be other components that might make it seem like that. I think you just need that would be a scenario where you would just need more assistance, you know.
Thank you.
Thank you, Dr. Tam. I think we have one other question in regard to language fluency. Is there an equivalent test developed for non-English fluent patients?
Yeah, I think Melanie was trying to answer some of this too, but I mean, Dr. Segal, you can help me on this also, but a lot of the different tests have been like some of them have been translated into other languages and use different versions, like slums and whatnot, and so they have data that support those too. The mini-cog is kind of another one that has that kind of ability to it too. The other component, not just language, is also their education levels. I mean, those are other things to factor in related to this.
I think
Yeah,
I could add to that as one of the neuropsychologists on the call here, Dr. Lucas. We have different normative data for each language. There's a lot of normative data for Spanish speakers, particularly from border states like Texas and California. And the stimuli is actually a little different. Rather than giving them a certain letter that may have more words that start with that in English, we'll give them phonemes that are more common in Spanish or Arabic or whatever the languages that they speak.
Thanks, Dr. Lucas. Yeah, Dr. Segal, I don't know if you know, but the main DCA site, are they posting other language-based translations of the different testing and the inventory?
Yeah, I think that's to come in a subsequent module is what I'm thinking. But thank you, Dr. Lucas. I actually looked up some data for the Korean speaking population, and there's a lot out there that's been looked at. So thank you for your comments.
There was one question directed at me about like any research. I think the research in like MCI and age, I believe majority of the ones, at least in this area, that are active studies are probably the older group rather than that younger group right now. That being said, that doesn't mean that there's not any ones that are out there. I think we just need to look, at least the ones that are within UCI, like research studies looking at you know, aducanumab, lecanemab, which are they have those studies ongoing. Those are generally the older patients in terms of the age cutoff, but around 50 is the number for these studies too. That's the other component of this. They would just have to call the research centers and then find out more information. I think that's probably the best way to go. And I think that was one of the other goals too, is that ultimately with DCA, Dr. Segal, you can correct me, but ultimately when they have that repository up, that they would have like, you know, linkages to the different research centers and whatnot. I think.
I will definitely confirm that and get back to you. Thank you.
Perfect. Thank you everyone for all the questions. Dr. Tam, do you mind forwarding to the last slide?
Can you see it?
Yes, thank you. So thank you, Dr. Tam, for your presentation. If you wish to receive CMEs, please fill out the form at the following link, or you can scan the QR codes. I've also put the links in the chat. We also ask that you complete the evaluation form, as this helps us with our continuous quality improvement efforts. This presentation and links will be sent in a follow-up email before the end of the day, so keep an eye out for that. Both of these forms will close at 11:59 p.m. on Tuesday, so please submit these as soon as you can. And also please join us next Friday, March 3rd for our 11th ECHO session on the topic of caregivers advanced care planning. which will be presented by Dr. Rahimi. I'll be sending out a Zoom invite at the beginning of next week for more information. So thank you again for your time, and we hope to see you all next week. Thank you.
Thank
Thank you.
everyone.
Bye-bye.